So we will just start. In the last previous two sessions, and we discussed about respiratory system and cardiovascular system. That what will be the precautions and what will be the anticipation which you will do when you have a patient with either cardiovascular disease or respiratory disease. So today, in similar fashion, we will just try to have a look at the liver patient with liver disease. So Sumera, what will be the same question, that what will be the possible symptoms and signs you will see in patient with having some liver problem?
Sir, patients with liver problems may have fatigue, malaise, loss of appetite,
Fatigue,
nausea, vomiting,
malaise, nausea, vomiting. What else?
fever,
loss of appetite. You are missing a very, you can say, the darling symptom of liver disease. Jaundice. Okay, this should be the first. Okay, what else?
abdominal pain.
Okay.
Itching.
Edema, itching. What else?
Loss of consciousness.
What about hematemesis or melena?
Hemoptysis melena.
And anything else? Any other symptom you think?
Weight loss, ascites.
Weight loss. Okay, weight loss. It may be weight loss. What about ascites? Ascites is a sign or symptom?
Sir, it's a sign.
It's a sign, but it is a symptom as well. Okay.
Right.
The patient can say that my abdomen is filling. Okay. Similarly, jaundice. Jaundice is a sign or a symptom. Can a patient with liver disease be anemic?
Yes, sir.
There may be bleeding history. Okay. So it may
Anemic coagulopathy.
Yes, because of coagulopathy. Okay. And when there is hypoalbuminemia, what is the symptom?
Edema.
Okay. So if you are not realizing, like this is a symptom, loss of consciousness is through the central nervous system. Okay. So there may be shortness of breath. Okay. Abdominal pain, as we discussed, and there may be cyanosis in liver disease, like shortness of breath. Of course, we will go to the signs. Okay. So I think these are the symptoms which you can have: abdominal pain, nausea, vomiting. There can be diarrhea as well, and fever, loss of appetite. And with reference, if you want to just have a think about CLD, think about jaundice, think about hepatitis. Okay, so at least if you think three things, you can recall all the symptoms. Okay, so now comes the signs. So what can be the signs?
Jaundice, ascites.
Jaundice, ascites.
Pallor.
Pallor can be, yes. Okay. Spider
Can be a sign of cirrhosis, like spider nevi.
this will, what is that? Palmer erythema. Okay. What else?
Gynecomastia.
Gynecomastia.
Pleural effusion.
Petechiae.
Petechiae, pleural effusion. Okay. Abdominal tenderness. Tenderness. Okay. What else? If
And
you
sir,
think
shifting
about
dullness and fluid thrill.
shifting dullness, fluid thrill. There is one CNS symptom which is you can say trademark.
Yes.
It's flapping tremors.
NCAF. Flapping tremors.
Flapping tremors.
Okay, and signs of uremia. Okay. So respiratory system, you can there may be sinuses. There can be sinuses or no?
Yes, sir. There
Sir,
can
there
be
can
in
be.
hepatopulmonary syndrome. There can be sinuses.
Okay, so hepatopulmonary syndrome. Okay. And what about what will be other signs in CVS? There will be signs of overloaded circulation.
Yes, hyperdynamic.
There will be some problems related to portal hypertension. Okay. Would you like to do?
Raised JVP.
Sorry,
Raised
your voice is not coming. Please speak loudly.
Sir, raised JVP.
Yes, signs of failure. Signs of right-sided failure. Raised JVP, edema. Okay. What else? There can be splenomegaly, like a hepatosplenomegaly. It will be, of course, it will be whether it is jaundice, whether it is CLD, or whether it is some. But like for example, like if we just try to, there will be something related to acute symptoms and something chronic. Okay, so just now think about acute symptoms and signs. So acute symptoms can be jaundice. Okay, pain, fever. Okay, so that will be more related to hepatitis, especially A, and fulminant hepatic C. Okay, because any hepatitis can be fulminant. Okay, and the other will be like in C, in chronic causes. Yes, one more is in acute, is actually slipped out of mind, is paracetamol poisoning. Okay, that will also be, or any poisoning acutely. And chronic, maybe because of hepatitis, or there are so many other causes of because of copper, because of hemochromatosis. Okay, Wilson's disease, this. Okay, and biliary cirrhosis. So there are so many causes. So that will be, there will be something specific, but usually you will be doing the abdominal examination. In that you will find this fluid thrill and shifting dullness and hepatosplenomegaly, ascites, and tenderness. Okay, and respiratory system, there may be dyspnea, pleural effusions, like decreased respiratory parameters. Okay, so this is how you will be just evaluating the patient. So what will be the next step, the investigations? So what will you find in CBC? What can you find in different conditions in liver? Like what should be in your mind?
Anemia, decreased platelet count.
Decrease platelet. Okay, WBC may be high. There is a condition which occurs in such patient. What is that one? Spontaneous bacterial peritonitis. Okay. And there is something related to bacterial translocation. Okay. So that will lead to signs and symptoms of uremia. So WBC is very important. So similarly, anything else, anemia, WBC, platelets. What about electrolytes?
Hyponatremia.
Hyponatremia.
Is this hyponatremia? Because actually there is activation of renin-angiotensin aldosterone system. So actually it is dilutional hyponatremia. Okay. Mainly. What about potassium?
Sir, it depends whether the patient is using spironolactone or not.
Yes. So usually whenever, you know, there is a hint, spironolactone is something else. Think about the main pathology. So mainly there will be hypokalemia. Okay. Because there will be this aldosterone is increasing the sodium and decreasing the potassium. Okay. So actually potassium is low according to the theory. Okay. What about calcium?
Sir,
Ionized,
hypocalcemia.
ionized calcium will be decreased. What has its relation with this albumin and globulin ratio? Yes, Sumera.
Sir, calcium bound with albumin,
Okay.
and when there will be low albumin in the body, then there will be free iron, calcium, increased free calcium.
There should be increased ionized calcium. Yes, Usman.
Sir, decreased albumin causes decreased calcium, I think, if I'm not wrong.
Zishan Ahmed Chitta.
I always forget this concept.
Yes, you are my brother. You are, you know, this all the problem with this name. All Zishans forget this thing. Even I am not able to recognize, recall it. Okay, just pardon me for this thing. Just confirm it because there is something related to ionized calcium. I think it should be low, but I don't know how. Because theoretically, that's what I was confused,
Yes,
that if albumin is low, then ionized calcium should be more theoretically, but I don't know how it happens. But there is something. You know, is it something related to vitamin D and stuff? I think vitamin D is mandatory for calcium absorption. So I think it is related to this thing that there is hypocalcemia. Okay. So if I'm not wrong, it is, reconfirm it. I think it is related to this thing. Okay. Because when there is liver failure, there is problems with vitamin D metabolism. Okay. Okay. So some word about, what about liver function test? What do you mean by liver function test? One is synthetic function. What is hepatocellular damage? Okay. And one is this like obstructive. So synthetic function, you see ETINR, okay, APTT, and What else? Albumin. Okay. So hepatocellular damage is this ALT, AST, gamma GT. And obstructive, you see alkaline phosphatase. Okay. So usually,
Sir, there is a relationship. I have Googled it. There is a relationship between the albumin and calcium, as I've mentioned that low albumin causes decreased calcium and high causes high.
decrease what? Decrease ionized calcium?
Sir, I'll confirm. Sir, it's written only calcium, not ionized.
Okay, no
or
problem.
unionized.
You
It's
can
just written
recheck.
calcium.
Because there is something relation with vitamin D as well. That's what I remember. Okay. So anyways, so this is how, and what else test will be for liver function? Ultrasound?
Bilirubin.
Yes, bilirubin. I'm sorry, bilirubin. So that will also be increasing in obstructive ultrasound, CT scan. Okay.
In obstruction, there is ALP that is increased.
Alkaline phosphatase, yes. In obstruction, there will be increase in alkaline phosphatase. This concept I always forget. I don't know how many times I have read it. One is direct bilirubin and one is indirect bilirubin. And one is conjugated and one is unconjugated. Okay. So of course, this conjugation is occurring in the liver. So if there is too much hemolysis, so there will be unconjugated bilirubinemia. Okay. And in obstruction, there is conjugated bilirubinemia. But I always forget the concept of direct and indirect hemoglobin. So if anyone can explain.
Unconjugated is direct.
Unconjugated is direct.
Correct.
Okay. And then they calculate the total bilirubin and subtract direct to calculate the indirect. Am I right?
Yes, sir.
I think it is
Sir,
like
unconjugated bilirubin is indirect bilirubin.
is indirect. I don't know. I don't
Correct.
remember it. So apology for that.
Sir, conjugated is direct. Sir, conjugated is direct and
Conjugated
indirect
is
is unconjugated. Yes.
Unconjugated indirect.
Yes.
Okay. Actually, this is laboratory stuff, and I'm sorry. And one more thing I don't never remember is this Coombs test. I have read about. I think
Direct Coombs test, indirect Coombs test. You read so many times again, you forget. Yes.
yes. So apologies for that one. So I am happy that I am not the only person who forgets. There are at least 2 people in the world who are like me. Okay. So
Sir,
actually,
in direct, there is a direct antibody antigen test. In indirect, you first take, you first mix the antigen antibodies and then you mix the reagent.
yes. Anyways, we will one day, inshallah, before I die, I wish to memorize it. Okay. Anyways, so okay. So up till now, whatever we have discussed about history, examination, and investigation, on the basis of that, usually the thing which we use is just Child-Pugh score. Okay. So according to Child-Pugh score, you will be categorizing the patient in that how severe is the damage. And so what are the parameters? It is bilirubin. Okay. It is encephalopathy.
SITs.
Okay. It is SITs. Albumin.
And PT.
And this INR. Okay. So actually remember Mr. Bean. Okay. So it is Mr. Bean.
So the mnemonic we made was base PTINR.
Okay. Whatever
EAS, bilirubin.
mnemonic is just like clothes, whatever you want to wear. Okay. So
Mr.
according
Bean
to,
is good, sir.
yes. So Mr. Bean is also good. Okay. So you will classify it A, B, or C. Okay. And whatever score you find, the method is that if it is in B, you will not let it to B or C. If it is in C, you will try to push it to B or A. Okay, so that is, and how, what can be you do to correct these things? Like you can drain the ascites, you can give albumin, okay, and you can give FFPs, okay, to correct INR. You can this one give this protection of gut to prevent encephalopathy like lactulose. Okay, you can give some antibiotics to treat the SVP. So this is how you can maneuver this ABC. Okay, so this is the main thing. You see, if you have a like Sumera, if you have this long case, so if you just want to think, the bottom line should be that whatever evaluation you are doing, just try to find out where the patient lies. Okay, and then you will be you will be optimizing the patient like that. So you will be giving albumin, you will be draining ascites, you will be giving FFPs, lactulose, and antibiotics. Okay, so the aim is to in that way you will be able to
Categorize or prioritize.
categorize, and actually this is what is your goal is. Okay, your goal is, so you will categorize it, and what precautions or what should be you ready for, Sumera? Like you have a patient with liver, so just like we did it for respiratory system and cardiovascular system, what precautions or what things you should be doing? If you think about monitoring, what should you do?
Sir, during monitoring, like standard 1 and standard 2 monitoring.
Then what else may be needed? Invasive BP may be reading, and it may be required, or cardiac output monitor. Okay, or even in certain scenarios, if you need to give vasopressors, you might need to use CVP. So this is related to monitoring. Airway management.
Sir, airway management, in these patients, there can be a risk of aspiration.
Risk of aspiration. Okay. So risk of aspiration. So you are doing rapid sequence induction, but at the same time, there may be hemodynamic instability. Okay. And you have to do the laryngoscopy and everything cautiously. Okay, because this can cause bleeding. This is another thing. And what else? You can make the ramp position to help your intubation, because the abdomen may be very enlarged, okay, and it is pressing the lungs, so there may be problems in the ventilation. Okay, so the ramp position may help. Then some other points related to pharmacology. Okay, so IV induction, just think like that: IV induction agent, inhalational, okay, neuromuscular blocking agents, liver, the local anesthetics, analgesics. So just think, what should be the difference? IV induction, any specific thing you should be taking care of?
Sir, you should reduce the dose first of all, and you will do in a boluses so that the patient might not be, he should be hemodynamically unstable. So you have to take care of this.
Okay, just one thing I forget, I will add is pre-medication. So you will be doing acid prophylaxis. Okay. Would you like to do enzylysis or no?
So depends if the patient is in encephalopathy or not. It depends.
Cautious.
Or if you want to give it very
Cautious.
cautiously in low
Cautious.
dose, and if it is in encephaly, I think we should avoid it.
Yes, like you can use propofol, or If the patient is hemodynamically unstable, then ketamine with midazolam and fentanyl. Okay. Among the inhalation agents, best is desflurane and worst is halothane. Okay, because desflurane has least metabolism, so it is good. Okay. Among the muscle relaxant, what is the best is cisatracurium. Okay. What will be the effect of succinylcholine? It will be prolonged.
It will be prolonged.
Okay. So otherwise, the medications which are metabolized like rocuronium, okay, and vicuronium. Pancuronium is the most, okay, but these also have some metabolism. So the best one is cisatracurium or atracurium, okay. So that is about this thing. So what about local anesthetics? Esters are better, but of course esters we are not using much. So amides, among the amides, lidocaine and bupicaine, the doses should be reduced. Okay. Okay, what about opioids? Best is remifentanil. Okay, fentanyl may be used. Morphine avoided. Okay. What about pethidine, ketamine?
Meperidine.
Meperidine. Is there any difference between pethidine and meperidine?
No, sir. Same thing.
Same thing. Okay. So meperidine and pethidine is the same thing. Meperidine, I think, is used in USA and pethidine in UK, if I'm not wrong. Okay. So what about NSAIDs? You will avoid because of risk of bleeding. Paracetamol. Is it contraindicated or you should be reduce the dose?
So reduce the dose.
Therapeutic doses, there is no harm.
Yes, you should be cautious about the doses. Okay. And reversal agent.
I don't think any.
Because it is it's excretion in kidney disease, the duration of action of neostigmine is increased. Okay. Okay, because Sumera, when they will be asking long case to you, they will be asking in the similar fashion. Okay, because sometimes you will not be able to like plan your answer. So like you should be taking care of HDU. Okay, some other things. Other important thing is you have to do the contact precautions. Okay, because this patient might have hepatitis C, hepatitis B. Okay, so the occupational profile preventions, patient might need HDU, ICU monitoring. Okay, and everything will be problematic. Okay, like if the patient has developed hepatorenal syndrome or hepatopulmonary syndrome, so there will be problems like that. Okay, so that's how you will be planning. And if they are asking you if you have a long case of this one, your aim should be like this, because if you plan your answer that what is the aim of asking so many questions, what is the aim of doing the examination, what is the aim to do the investigations, sorry, this and then you will be interpreting, you will having the status of the liver and what are the risks involved. So there are problems related to drug metabolism and drug dosage. Okay, initial dosage may be increased because of increased volume of distribution. So sometime you might need to give some more doses because of increased volume of distribution. Patient is overloaded. Okay. So this is one point, and the rest of the points I've discussed. Okay, so ultrasound, CT scan, cardiac output monitoring. So I think that's all. That's it. These are main important thing. Just let me have a look on the article. Maybe we will find something.
Sir, what about choice of anesthesia, regional versus general anesthesia?
Yes. Would you like to give regional anesthesia in these patients?
Sir, it will decrease hepatic blood flow.
Hepatic blood
Regional
flow?
anesthesia.
No, my dear. This will cause epidural hematoma. If the patient is at risk, always avoid. It is better not to do it. Yes, if you have more.
Sir, if there is no coagulopathy, then we can go for neuraxial block. Is it okay?
Sumera, you know, in the
But they
exam,
will not give you that much case. They will give you a Pakawa case in which the patient will have definitely coagulopathy,
So,
hemodynamically instability.
yes.
So
So,
they
you know,
will not
my,
give you ASA 1 or 2 patient.
yes, you know, my suggestion is that unless there is a strong need, you can always have answers like you will be doing the risk versus benefit assessment. Okay. You will be doing the risk versus benefit assessment. And then if there is some advantages, then you will consider. Otherwise, it's always like, for example, if you have a patient, you deep blocks, even deep blocks are problematic because there may be development of hematoma. So similarly, epidural, I never do blocks in patient with liver disease like that. This especially central neuraxial. Okay, so unless you can say that I will evaluate the patient. If there is no coagulopathy and there are some advantages, then we can consider with care, with caution. Okay.
My case was of cirrhosis in long case in part 2, and it was a full-fledged blown case of cirrhosis with every complication.
So, you know, one complication of liver failure I saw a few days ago, and it was not my patient. There was a patient who was lying flat, very obese patient. And then the patient was fighting because naturally the doctors were trying to make him prop up. But as soon as he was getting prop up, he was getting irritable, short of breath. And when he was lying flat on the bed, he was okay. So can anyone tell me what is that condition which can develop in liver failure? Which will
Yes, sir.
cause
Portopulmonary syndrome.
portopulmonary syndrome, and this condition is called as platypnea orthodeoxia.
Yes, it's written.
Platypnea orthodeoxia. Patient is dyspneic on sitting, and patient is stable while lying flat on the bed. Okay, this is because of AV shunting. You can read about it. Okay. So there may be, yes, in optimization, I forgot to tell you about vitamin K. Okay, so you can give FFP, scrap precipitate, or this DDAVP, desmopressin, okay, to correct the coagulopathy. Okay, so nutritional support you can give, and gastric emptying aspiration risk, as I told you. Monitoring this cardiac output monitoring, they have written about this T and everything. Okay, choice of anesthetic, propofol, and agent, alteration of protein binding, decreased synthesis, impairment of drug metabolism, detoxification, and excretion. Okay, so absorption, distribution, metabolism, excretion of are likely to be affected. Okay, so that's it. I think this is just a baseline for you people. So inshallah, tomorrow or day after tomorrow, we will try to do in similar way renal system. Okay, so thanks a lot, all of you, and You can view the, like, you can see the recordings, because before I did in this very maybe 7, 8 or 10 sessions on preoperative assessment. So I'm just trying to quickly, I'm just trying to do it, because this is, remember one thing, this is not only for long case, this is for all your patient assessment, because maybe daily you are doing it unintentionally, and you don't know. And for juniors, if you make your approach like that, that whatever you are asking, even investigation you are asking, you should be knowing the reason, because there should be a reason for everything. Okay, so that's how you will be stratify the risk. You will label it as high risk patient or intermediate risk patient or low risk patient, and then you will accordingly act. Okay, so thanks a lot. Inshallah, we will meet again. Thanks Usman and Zishan for joining. And thanks Dr. Munawar as well. It should be for resident, but alhamdulillah, not what residents are interested, except for Anika and Yasin and Mozzama. So Dr. Munawar, I think you should again start training, because you have more energy than these lazy ducks. What do you think? Are you Dr. Munawar from Sheikh Zayed? Am I right? If you are not that one, so apology for that. I thought that you are Dr. Munawar from Sheikh Zayed Hospital. Anyway, thank you very much. Inshallah, we will meet again. Assalamu alaikum.